Good morning, everyone, and thanks so much for joining our Clallam County EDC Coffee Chat. We are really excited to have our member, partner, and friend, Dr. Michael Maxwell, join us this morning, and the CEO of North Olympic Healthcare Network. And he's going to be sharing about what's been going on there in their world. Very quickly, if you'll put yourself on mute so we don't inadvertently pick up any background noise, that would be great. And if you want to ask some questions, either raise your hand and we'll call on you, or you can put it in the chat and we can ask the question on your behalf. So with that, Dr. Maxwell, please take it away. And thanks so much for joining us.
Yeah, you're welcome. Thanks for the invitation, Colleen. Glad to be here on this beautiful rainy Tuesday morning or Wednesday morning, and I'll hopefully give you something of interest, make it worth your while. I'll say my apologies at the front end because I noticed there's a lot of familiar faces from the last time I did this a few years ago. So some of this may be a little bit redundant, but hopefully it's maybe your memory's bad and we'll all seem new to you again. Who knows? But hopefully it will be worthwhile. Colleen and I practiced sharing this, so we will see if this actually works. How's it look, Colleen?
Looks great. Thank
Awesome.
you.
All right. So the place I always like to start with, so again, welcome everybody. I'm going to give you a little update today on some updates on our some new sites that we've opened up, some new services, and what we have planned for the future at North Olympic Healthcare Network. I always like to start with our mission, which I try and get every one of our staff to memorize. It used to be a 2-paragraph monstrosity, but we got it pared down to a pithy phrase that I think really does embody what we're all about, and that's to provide patient-centered, quality-driven, whole-person healthcare services that we make accessible to everyone in our community. And I'll give a little bit of context to kind of help everyone understand how we got there, but each one of those words has a lot of meaning for us, and we take them all very seriously. Just starting out, I think, with a little bit of background, because I think there's still a lot of misunderstanding and misconception about what we are, what actually a health center is. You hear that term used a lot, but in our context, a community health center is a very specific entity, and it has a lot of requirements to go along with it. And I think it's always helpful to help people understand the community, what that's all about. But how we got there, we started out, so we are a 501c3 not-for-profit federally qualified community health center, or FQHC. And that's that very specific beast I was mentioning to you all. We were, as North Olympic Healthcare Network, we were established in 2015 after transitioning our 40-year private primary care practice into this community health center model. That prior entity was known as Family Medicine Port Angeles. Those who've been in town for a while might recognize that name. But what we, despite having a really successful practice and doing a lot of good for the community in that model, we really had to recognize that that model was no longer working. It just wasn't effective for meeting the needs of the community at the time we made the transition and projecting forward. For those of you who were around in 2014 in Port Angeles, you may recall that if you wanted to get a physician and you didn't have one, you simply were not going to find one. There were not enough primary care providers for our community. And that was for a variety of reasons. We had, there were national shortages of primary care physicians. We had a lot of retirements. We had a growing population of people who gratefully, were gaining access to health insurance through the Affordable Care Act, but it didn't help them because there just was not enough physicians to take them on. And in our particular situation, as a private practice, that was the model which had been predominant for decades, where physicians, when they finished their training, they would go out and set up a practice, or they buy into a practice, and then they would be owners, and then they would run the business and run the and see patients as well. And in the generations over time, that model just was no longer attractive to new physicians who were finishing the training. They just wanted to focus on seeing patients. And so for us as a private practice, we were having a hard time finding anyone who was interested in that model about coming in and being an equity holder and doing the work of running a business. So we had, as with retirements and relocations, our provider base was shrinking. We had all these patients to take care of, and we had to turn other patients away because we just couldn't. We just didn't have the manpower to do it. And so we just had to recognize that model that we had been serving so well for so long was just not meeting community needs. So we saw in 2014 there was an opportunity to apply for what's called a new access point grant through HRSA, the Health Resources Service Administration. That's a branch of HHS, the federal government. And HRSA makes these grants available on a competitive basis for communities that are underserved medically. And we were aware of this, and we had been contemplating, what's the right long-term model. And this seemed like it was going to be the right thing for us and for the community. So we applied for one of these competitive grants. There were about 2,500 applicants. We were one of 164 that were awarded across the country. And we were one of two applicants in Washington State in 2014. And we were actually the last community health center in Washington State. There's been none since, new ones. So it's a very competitive grant, and we had a compelling story about the need in our community and that our ability as an entity to meet those needs. So we were reborn as North Olympic Healthcare Network in September of 2015. And really our goal was by adopting this model that we really wanted to improve the access to comprehensive primary health care across the community. And we thought that this model would better enable us to do that. So what exactly is a community health center, or CHC? You'll see these terms, Federally Qualified Health Center, or FQHC, and the term Community Health Center, or CHC. They are synonymous terms. They mean the same thing. The FQHC is often used in reimbursement contexts, refers to a reimbursement model. Community Health Center is the clinical model, and that's my preferred reference, but you may hear me go back and forth. If you see one, it means both. Community health centers, in a nutshell, are nonprofit, community-based, and patient-centered or patient-directed organizations. That's real important. I'll get to that in a minute. Patient-directed organizations that serve populations that have limited access to healthcare. The Health Center program started in 1964. It was actually an extension of the Civil Rights Movement. At that time, there were large populations which were often inner city or rural and poor that just did not have access to important important services like healthcare. And the Health Center program was predicated on the idea that healthcare was a basic human right and that everyone should have access to health services. And so this legislation was signed into law by President Johnson in '64 to address those underserved areas. The idea was, and it was sort of radical at the time, that health centers would provide comprehensive, integrated primary healthcare services. And we kind of take it for granted now that we think it's a no-brainer. And of course, the outcomes are better. It's more cost efficient if all of your healthcare services are within an integrated model where all your different providers and specialists are all talking to each other. All different facets of your healthcare are all coordinated and working together. That's not always been the case. I mean, the health centers back in the '60s were the very first to have this idea that you can and should get all of your primary health services in one place through a coordinated system where providers talk to each other. So the health center program has really been a model for the healthcare of the future that has evolved. So like Kaiser and so forth. It started out as two health centers in 1964. There was one in inner city Boston and the other one in rural Mississippi. And from those two health centers, it has gradually expanded over this subsequent 50, 60 years to now 1,400 health centers in all 50 states. And as I said, known as newest one in Washington State, where there are 27 health centers in all throughout the state of Washington. Collectively, health centers serve 31 million people. 9 million of them are kids, and almost 500,000 of them are veterans. And it makes us one of the largest health systems, if you think about it as one system in the country. So there's some fundamentals about the health center. It's actually a very complex environment, but there are some fundamental concepts that are key to the health center program. As I mentioned, health centers are there to serve high need areas, so populations or communities that have limited access to healthcare. So there's something called the Health Professional Services area, or I'm sorry, Health Professional Shortage Area. That's a HPSA, or medically underserved area or population. Those are designations that the federal government looks at based upon the access to health services in the community, and they give you a score. And the higher the score, the greater the need. And Port Angeles had a very high score, and which is reflective of our need. So that was one of the key features of our application, was to describe that need and tell them that we'll be able to address those needs. The other key fundamental is that the healthcare in the philosophy of the health center program is that the healthcare is responsive to the patient's needs, the patient's and the community's needs. And from this very first days, health centers, one of the requirements is that it is governed by a board which is comprised of patients, of consumers of that healthcare. So that you're always the health center is always moving towards meeting the needs of those patients. Those patients are part of the governance. They don't run the health center. But they set the goals. They set they approve the services, the various policies. We're fortunate. Actually, I think on the call we have a couple of our board members. NOHN has some outstanding board members. Tom Sanford, Susie Ames are on the call. They're on our board. I just want to take a moment to acknowledge the tragic passing of one of our other board members, John Brewer. He was just a big part of our board and believed in what we were doing, and so his passing was a real loss for the whole community. But we definitely feel his loss. Are grateful for the time he served with us. So we are patient directed. We have a patient directed board. As I mentioned, the services that we provide must be comprehensive. That means it have to be a full range of services, primary care services. The other key feature is that nobody is turned away. So in a health center, anyone who walks through our door can get care, whether you're insured or not, and it doesn't matter what it's not based on your ability to pay. Our outreach navigation staff will try and connect people if they qualify for insurance. We'll try and help get them set up. But if they don't, they are still seen, and based upon their household size and income, their charges are reduced all the way down to zero if they qualify. So if you ever hear someone say, "I can't afford to see my doctor," no, that's not true. We will make sure that cost is not the barrier. We are health centers by nature are collaborative. As a private practice, we took really good care of our patients. We were kind of directed, kind of inwardly focused. But as a health center, is a completely different model. It is outwardly focused, looking at collaborations in the community, working together with others to try and identify needs and try and address those needs. I'll touch on some of those collaborations a little bit later. And the other important one is that we are very accountable, because I think 5% of our budget comes from a base grant that we get from HRSA, but with that comes for the privilege of having designation as a health center. There is a lot of accountability. We have over 320 separate regulations that we have to be in compliance with at all times, or we can lose that designation. We have to we're subject to a federal site visit every 3 years. We have to supply HRSA with data about cost, utilization, staffing, clinical outcomes. We have to provide provide that every year, and some reports almost weekly. And then every 3 years, we have to go through a process of what's called a service area competition to basically reapply for the privilege of being a health center. We have to say that we still understand what the community's needs are, and that we are effectively mustering resources to address those needs. So what's been the impact? So we went through all this and are doing this to maybe remember back to make sure we could get more physicians, more healthcare providers in the community. And we thought that this model would do that, and we've been successful. In this model, we've been able to recruit 15 new physicians over the past 9 years, and 10 nurse practitioners or physician assistants. These are new healthcare providers to our community.
And so, Mike, how many did you have prior to that under the family medical?
We had 5 physicians and 3 nurse practitioners.
Got it. Yep. So expanded dramatically.
Dramatically, and all those patients we had to turn away, we were gratifyingly able to give them a medical home. We've had over 12,000 new patients since we've been a health center, and the demand is still huge. We take in about 150 to 200 new patients every month, depending upon our provider's capacity. We now have over 17,000 active patients, had over 60,000 visits in 2023. About a third of our patients have Medicaid as their insurer. More than that, the majority are Medicare, reflective of our population, and our smallest is commercial population. We do have uninsured, and thanks to the Affordable Care Act and some of the pandemic relief, Medicaid expansion, a very small uninsured population. Although with Medicaid redeterminations, many of those are losing their Medicaid coverage, so they're becoming uninsured, but they still have a place to come to be seen. We'll make sure that they're taken care of. As I mentioned, we're a safety net provider for the uninsured and have a sliding fee scale. We've been able to beef up our behavioral health staff, or behavioral services as a community health center. We have licensed clinical social workers and have had psychiatric providers. We mostly focus on treatment of the common primary care conditions like depression, anxiety, and there's a lot of it. We are not a full service behavioral health center, community health center like PDH. I mean, they really have the expertise and the resources to take care of the really severely mentally ill. But that's not our. We don't have the resources or expertise of doing that. But there's a lot of more common, straightforward issues that are prevalent that our behavioral staff works alongside our primary care staff to help provide that care. We are able to provide new dental care access for children and adults with Medicaid. I'll get to this in a bit, but adults with Medicaid in particular have had historically a very difficult time finding dental care because of the low Medicaid reimbursement rates. And our dental access has really changed that. Before we opened our dental clinic, most adults with Medicaid were going to ER with advanced tooth decay, abscesses, tooth loss, chronic pain to get their dental care, and that's no longer the case. And we, in investment in the future workforce, we have really had a long time desire to open up a residency to train family medicine residents. This is really Dr. Rob Epstein has really had been a passionate advocate for medical education, and this was one of the things we had dreamed about doing together. And as a private practice, it'd be very difficult to do. It's already hard enough as a community health center, but it's feasible, and we'd be able to pursue that effectively. So some quick milestones. Our Nexus Point grant, as mentioned, that we got late in 2015. And I'd like to say we actually started the process of the grant application in 2014. We heard about the grant award in May of 2015, and they gave us exactly 120 days to become fully operational as a community health center by September 1st, but we were able to pull it off. We opened up a medication-assisted treatment or office-based opioid therapy for patients with opioid use disorder. We started that very early in our existence. This is something that caused quite a stir out in SQUIM with this, the Jamestown Healing Clinic is something that we've been doing since 2016. Jamestown has a broader range of wraparound services and do it just an exceptional job. We're really happy that they're providing that service. We've been providing this since 2016. Started our Rural Training Track Residency Program in 2017. Started a behavioral health program by employing our own staff in 2017. We kind of outgrew our current space and opened up our expanded services building in 2018, mostly to house our behavioral health staff and to prepare for dental later. We opened up a clinical pharmacy program by having pharmacists working alongside our primary care providers to help with medication management. Opened up an administrative center next door to the old Cowboy Country later that year. And this made room to build our dental clinic. We have a 7-shared dental program in the ESB building. We got recognized for patient-centered medical homes level 3 recognition by the National Committee for Quality Assurance. I won't go into it. It's a big deal. It's a reflection of our commitment to quality and our patient-centeredness. Then this little thing called pandemic hit us, and it sort of changed upended our world like everyone else's, but it really accelerated our adoption of telehealth services during that time. It's something that we want to continue to expand and make available. We helped out with a mass vaccination clinic with the health department. That was a big push for us at the end of 2020. We started a mobile health clinic in 2021. It was supposed to arrive in 2020, but the pandemic slowed us down. We've been, I'll touch on this later, a collaboration with the school district to bring services to students in the district. We've expanded our outreach program to bring on community health workers. It's a new kind of workforce where it's often peers who are working with people in their homes to try and help identify barriers to care and overcome those barriers. We got PCMH status for our ESB site in 2022, and then opened up our most recent facility is the Eastside Health Center that I'll touch on here a bit more. This was allowing us to bring on new services, including vision. During this time, this has been a growth of employees from 35 up, we're close to 170 now. Our number of patients has grown, as I alluded to earlier, and the number of visits that we've been providing during that time has gone up substantially. And what's on this graph is the color of my hair has changed. I was not this color at the start of this, but I am now this color.
That is a huge, amazing success. And just the fact that you got that grant has been, really pivotal for our community. Who wrote the grant for you? Was that a huge undertaking, or do you feel like you just got a little bit lucky? Or a bit of both?
I think a bit of both. I think we had. I mean, the grant itself is like. I mean, you see these things, Colleen. I'm sure you do. I mean, they're huge, and we got some consultants to help write. I ended up helping write probably 80% of it. Work with the consultants who kind of knew how to work the system. But I think we had a compelling story, and I think we told it well. And I will say that we did get the support from our congressional delegation. So Kilmer, Murray, and Cantwell all wrote letters of support, which I think probably carried some weight. We had actually very broad, lots of letter support. Many people on this call provided us letter support back then. And so I think it was the community was behind us, and it was the right thing at the right time, and HRSA recognized that.
Yeah. So what's your next big milestone?
You're foreshadowing my last slide.
Oh, sorry. Okay.
That's okay. Just to highlight some of the collaborations I mentioned earlier. We have been active in the Olympic Community of Health, which is a regional health collaborative that was established by the state about 8 years ago. And this is where healthcare providers and community-based organizations and other stakeholders work together to kind of tackle kind of broader systemic health issues. that no one of us can tackle by ourselves. And we're really fortunate to many people on this call are also involved in the OCH. I mentioned our mobile health clinic for the school district. The behavioral health, we started with thinking that there's gonna be a lot of primary care needs, that there were illnesses that were keeping kids from graduating and trying to bring services to the kids. But we've learned that, at least since the pandemic, the vast majority of the needs are around behavioral health. So we've had a lot of behavioral health providers staffing that unit, getting most of the activity. Chief Ken Dubuque many years ago had this idea, spoke about community paramedicine. And I think others on this call have talked about that in other contexts. But the fire department really wanted to try this idea about getting, instead of just responding to calls, trying to be proactive and reaching out and addressing the high risk, high need people in a different way. And we've been supporters of that, both through collaboration and through financial contributions. Back in 2019, I wrote a grant. I was successful in getting a grant that allowed us to help the program expand to 3 paramedics. We're really pleased to see that I think the city and others see the value in this and are trying to find a way to make it sustainable. But it's a really impactful part of the care network in our community. As I mentioned, the mass vaccination clinic with the collaboration with the health department back in 2020. The Rural Training Track program, I mentioned our collaboration with Swedish and OMC. So it's a residency program. The residents start out with 2 residents per year, and a few years ago it expanded to 3 residents per year. They do their first year at Swedish Hospital, and then they do the next 2 years at North Olympic, doing their ambulatory care training with our physicians. And they work with them at the hospital on their inpatient care. OMC, the OMP specialists do some of the training as well, and it's been a real nice collaboration. The idea is that if you train them in the community, they're more likely to stay in the community long term. And our newest collaboration is with a food bank. They are bringing a kind of mobile market to our EHC parking lot. I believe it's every week. And that just got started, and they're trying to get out to where the people are as well. I mentioned that a key part of what we do is assessing needs and trying to address those needs. And a part of what we do at least every 3 years is a formal community needs assessment. The last one we did, we found that there's still, despite our expansion, there's still a huge amount of demand for primary care. We've had a wait list that grew longer than we wanted, and we've done a good job whittling that wait time down. But there's more retirements on the horizon. There's still new people coming to the area without physicians, and there's still a lot of unmet need. So we tried to work with our board and try to get out in front of this, and so we went forward with developing a new service site that went live just a little over a year ago. It's the Eastside Health Center. And this would provide additional primary care access, as well as ability for behavioral health and some telehealth. And importantly, we really wanted to have some place to be able to offer this new service, vision services, particularly for those with Medicaid who have trouble accessing those services elsewhere in the community. I think I talked earlier about this, Colleen. We sort of thought that this would add about 25 living wage jobs, push up over 170 employees when it's fully staffed. It ended up being about a $5 million project, which was actually twice as much as it was when we started on the process. But you get on the train and you can't get off, and so it ends up costing twice as much. We finance that through a combination of some personal loan guarantee loans, some capital grants, and dipping into our reserves, our limited reserves. And I just do want to take a moment to acknowledge First Federal Community Foundation for providing $25,000 towards equipment for the New Vision services. I'll just blow through.
And you actually, going back to that That was $5 million, but it's a really big facility with a big footprint. And the price per foot was actually really reasonable considering it was a public works project.
Yeah, it's you're correct. Yeah, it could have been worse. It was worse than I wanted, but it could have been much worse. And it's just,
Yeah.
we're a young organization, so we haven't had time to really build up, deep capital reserves. And so anything which sort of dips into those makes us all a little bit nervous. But the board understood this was an important investment, and it was the right thing to do. So we moved forward with it.
What cost the price to double?
The pandemic, because this happened right in the midst of the pandemic. All the supply chain issues, workforce issues, all those just really contributed to the cost of supplies and labor.
Got it.
I'm going to blow through these pretty quickly to make sure we finish on time here. But just I thought, for curiosity, people like to see just sort of the evolution of the space. So there's the arrow shows what, I'm not sure what the date. This is an old trade well here, but behind that is our current site. This is what it looked like in 2018. Then Fanaticus did a substantial remodel to the exterior and interior. When we made an offer on the place, this is what it looked like with Edna's place, and we didn't make a whole lot of changes to the exterior because that was in pretty good shape. But the inside, we did a substantial, as you'll see, renovation. So this was what the upstairs, a lot of people didn't know it had an upstairs, but it had about 4,000 square feet upstairs, and this is what it looked like. It was all storage facility. Edna, out of the kindness of her heart, was using this for allowing nonprofits in the area to store stuff up here, for like OMC Foundation and KOMP and so forth. In fact, KOMP got wind of the sale first because Edna said, you have to move your stuff out. So they said, what, why? And so I got a call from KOMP. But that's what it looked like when we started. That's what it looked like mid-renovation. And this is what it looks like now. Yeah. So a big change.
It's awesome.
Again, upstairs.
I got to tour. It is a really amazing space.
Yeah, agreed. Thank you. It's turned out even better than I would have expected. Mm-hmm. Those who are familiar with the lobby, that's what it looked like. That's mid renovation, and that's the as you walk in the front doors now. The main area, again, gutted, and it's become a waiting area. This was back in the kitchen area. This is as we gutted it. There were some surprises here. This is one of those cost escalations. So we came to find that there's been a lot of flooding in the area. The drains on there are not really fully equipped to handle all the rain, especially when you get big rains. And so we've learned that over the decades, there's been water damage and undermining. And so as we were doing some renovation there for the plumbing, we had to deal with some of that and mitigate that. But it turned out nice. Oops. Again, this is back where the providers are at. This used to be the old kitchen area. This is the back with the, I'm sure, fully safe and 2 code steps that were there that we had to change for some reason. So yeah, this is what the new steps are like. As you walk in the front door, looked off to the right at the old Edna's place. Was looking back at this conference room that they had back there that we gutted and turned into our eye care reception area. And then this is that conference room area that again was gutted and is where our vision services are housed. And speaking of vision services, this is just a quick timeline. So we executed our purchase and sale agreement in July 21. We had a kind of a long contingency period as we worked through all the complex financing. We did have a low interest loan guarantee program through HRSA that partnered with Kitsap Bank, which was made it feasible. We did our renovation, started that in February 22. We had a 10-month target completion timeline that actually held true. We used Insight architecture from Bellingham. Van Air did just a great job and made it very affordable to help with the project management. And Neely has done Boys and Girls Club and the food bank. They were just great to work with. There were lots of surprises in the old building. I could spend all day talking about each of these, but they were all kinds of surprises that increased the cost and pushed the timeline a bit, but we managed them just fine. So we occupied by December 2022, and we were delivering services beginning February 23, so just a couple months later. That new service was optometry. Dr. John Heward, who's been in the community for a long time. John was really committed to the community and doing high quality care. He was one of the few Medicaid providers that did a bulk of a few vision providers that did a bulk of the Medicaid care. And he just like so many providers, just the hassles of trying to deal with the business side and deal with insurance companies and just the fight to get reimbursed it's just wearing. And so he was my eye doctor, and we were in the middle of an exam, and he was lamenting. I said, "Hey, by the way, would you have any interest in?" And that was probably about 5 years ago. And so we started on this long, it's a very fortuitous exam. So make a long story short, he joined us in 2024. He closed his practice in December, joined us in 2024, in January, and a month later started seeing patients. And he has the space accommodates 2 full lanes with a full range of vision care. And I will tell you that I've learned that vision equipment is really expensive. It is painfully expensive, but it's important to have it. And he's just thrilled. It's been a win-win-win all the way around. We love having him. The patients love having him. He loves being at NOHN. So it's really a great.
Yeah. So he got rid of his headache and the business side of things. And is he able to see a lot more patients now since his time is freed up?
Yep. He can actually focus. He sees more patients than he would otherwise. And he says he just wakes up excited every day to come to work, which is just what you want to hear.
Yeah, that's awesome.
So the challenges that we've been facing, workforce is, as we've heard on this call, I think everyone who's presented on this forum talks about the challenges with workforce, just finding people who to do the work, especially when you talk about healthcare. We're in a limited market, and there's just unfortunately there's a lot of demand for those people and just not enough of them. The college is doing everything it can to help plug some of those holes, but it's just really painful. Staff childcare, as you've heard, I think I talked to you earlier, Colleen, about what opportunities were for us to address staff childcare needs. Just about a year and a half ago, it was just becoming really clear, especially after the pandemic, that staff were not able to come to work. Their daycare provider, child care provider would be unavailable. They have to call in sick to take care of their kids at home. Our providers, many of them are working mothers, small children. And when they lose their daycare provider, they don't have anybody. They have to cancel their clinic, and so it impacts patient care. So we really tried to see, okay, we don't want to do childcare because it's really hard, but no one else is doing it. So we were looking into it. We applied for some grants to try and move forward, but we weren't successful. But fortunately, during that time, as we heard, I think a couple weeks ago, Wendy Bart with the YMCA and then William Pool are having some successes in expanding access. So we're going to work more on partnerships with them to address this issue. Housing is, again, huge. We just, again, last month lost an important staff member because she lost her house. Somebody, her landlord basically turned it into a short-term rental, and she couldn't find anything else that was affordable, so she had to leave the community. So housing is a pain point thing for all of us on this call. Wage inflation is huge, especially in a market like ours where there's limited healthcare workforce, and there's Olmsted, Jamestown, Jefferson, all looking for the same people. And, I do exactly what they would, but everyone has to sort of try and up the wages and bonuses and all this, which really increase the wage inflation, which it gets to be a kind of a death spiral for those of us who are trying to employ them. It's really hard to be competitive and still stay sustainable. Health insurance costs are escalating at 20 to 30% projected coming up, and that's another pain point, particularly when we have stagnant reimbursement. Something I try and let my staff be aware of is that, unlike other industries where if the cost of my labor or the cost of my goods is going up, I increase the price that I'm selling those goods at to get more revenue. In healthcare, you can't do that. Your prices are fixed, they're set, and so the only way that you can increase revenue to address those additional costs is to increase volume, which is not good for patients, it's not good for staff. So it's just a real challenge. So trying to find other ways to be creative and supplement that revenue is a real challenge. And then political instability. I mean, we have a federal designation. We are subject to the shenanigans that goes on with the appropriations that happen at congressional level, and when there's this level of dysfunction, it just adds more uncertainty about just in our daily lives and in our base funding. So it is a ongoing challenge. And this is what you were asking about, Colleen. And this is my last slide, so I think I'll get us in under the wire. What we're really trying to do with this our Eastside Health Center is to get it fully staffed. So we've been actively recruiting. We've had some success. We have capacity for 5 additional primary care providers, and we're on a good target to get that filled. There's always sometimes we'll lose a provider because of a trailing spouse issue or some other issue, and so we are having to backfill that as well. But we're on target for getting the Eastside Health Center fully staffed over the next 12 to 18 months. Our vision service has been so needed and so successful. We're looking at actually expanding the number of providers in this coming year because the need is still so great within our patients. We're looking at extending services to the Forks and West End. About 7% of our patients come from the West End, and being able to bring care to them to save them the travel is something we'd like to do. We're looking real closely at this, making sure we really understand, is there a need? What are those needs before we invest in the effort and the capital to go out there. The other part is we want to make sure that we're welcome. We're only there if there's need, and if I want to collaborate with the Forks providers, Forks Community Hospital and Boca Shield Clinic. We're not there to displace them, only to supplement, bring things that maybe they are unable to do. But there's something, a point of active discussion that we're considering.
Great. That's great to hear. Because
Spending-
they don't have OBGYN out there anymore, right?
Yeah, delivering babies in a small hospital with a very small number of deliveries a year is a real challenge. And they do have one OB provider. Some of our providers go out there and kind of spell her from time to time, but providing prenatal care is one thing, but actually doing deliveries at a hospital when there's just so few per year is another set of challenges that Heidi's dealing with. We're looking to expand telehealth services. We will look to graduate more family medicine residents, and we're in active discussion with one right now who's graduating, who appears interested in staying, and a couple in the subsequent class who are also showing interest. So that's the payoff for the community for the investment in their training. We're trying to grow our community health worker workforce, as well as expand some of our collaborations throughout the community. And we're right in the midst of our 2025-2027 strategic planning. I'm working. The board and leadership are working on this now. It's be a 6 or 9 month process. Our intent is to get more input from stakeholders in the community. So some of you on this call may be receiving a little questionnaire or survey asking for your input about what you think of what we're doing, what we should be doing better, what should we be doing different, and I'll be interested in your input. And that is all. I'm under the wire. Yes, with 4 minutes to spare.
Fabulous. Well, I know, let's see, Rebecca put a really good question in the chat, and then Eric Lewis had a question as well.
Eric.
So Rebecca.
Go ahead, Colleen, if you don't mind.
Okay. Rebecca asked, regarding kids' mental health, what's the root? Pandemic, social media, isolation, lack of social skills, generations, addiction, other, what can be done?
Yes. All those things. As you touched on, Rebecca, I mean, it is so intertwined, multifactorial, trying to tease that apart. I mean, it really is, as you well know, it's incredibly complex, and there's societal issues, there's economic issues, there's just so much that plays into it, that it's all those things and more. But since we don't have 5 hours, I'll leave it at that.
And how much has it increased?
Boy, I don't have the data. I just anecdotally just hearing from our behavioral health staff that it's substantial. I think there's always been some challenges, but I think the pandemic really just we have not societally recovered yet. We haven't seen the full impact, and the kids are really feeling it. And because their parents are struggling as well, it doesn't help with the kids, and so it's really the pandemic played a big role.
Okay, thank you.
Yeah.
Eric, thanks for joining us, Eric.
Yeah, it's good to be here. I wanted to say hi, Dr. Maxwell, and
Hey,
your
Eric.
presentation was excellent information. And I think the community benefit that North Olympic Healthcare Network has provided over the last decade is under-recognized and should be greatly appreciated, because I was heavily involved in the healthcare community, as you know, and you consistently stepped up for your patients, our community. You collaborated with others, made a big difference. So thank you to you and your whole team. Because I think it's made a big difference in a very difficult healthcare environment. So thanks. And my question is, federal advocacy. I think the good news is community health centers have bipartisan support. But are there any big issues in Washington, D.C. that community health centers are advocating for that you're trying to get passed? And or what are the big issues in D.C., if there are any?
I think, number one, thanks, Eric, for the recognition. And I just want to say that you early on were a big supporter of support and helped us kind of get where we're at. So our collaboration with OMC while you were there was a big thing. So thank you. I think off the top of my head, probably the biggest issue facing us right now is probably 340B, which is a really complicated thing for this talk. But for the upshot, you know more about than most on the call, Eric. But it's a way of getting supplemental revenue to support, with this fixed reimbursement. You need every little penny you can to support these services that are unreimbursed or under-reimbursed. And so the 340B is a way to do that. And there are some threats to that on a federal level that really are concerning. If that goes away, I think many health centers around the country are going to close.
Yeah, no, the 340B discount pharmaceutical program is critical to rural healthcare, both community health centers and hospitals. That's an issue that, as you know, I work at the Washington State Hospital Association, and we're working on that issue a lot. It's big.
Keep it up. Yeah. Other than that, I think, as you said, fortunately, there's bipartisan support. I think virtually every congressional member, whether they have an R or a D after name, have health centers in their district that their constituents rely on. And so It is an area of commonality. I think there's right now there's disagreeing about how much funding should go towards it. Senator Sanders is proposing an expansion. Senator Cassidy is looking, is advocating for, lower spending and looking at health centers program as a source for savings. So I think everyone agrees that they're valuable. It's just how much support are they deserving?
Thanks.
Thank you, Eric. Good to see you.
Good to see you.
So you mentioned that, Dr. Maxwell, that there are 21 different regulations that you have to abide by. Is that more so than, say, OMC?
It's actually 320.
Oh, 320.
Yeah. And
Got that number wrong.
I don't know, Eric probably has a better idea.
A little bit more.
Yeah, I mean, it's depends on the way you lump or split. I split for dramatic purposes, but I'm sure the hospital has, I'm sure more, but they're similar, but at different scales.
Mm-hmm. Mm-hmm.
Eric had jet black hair too before he became a CEO.
Yep. So who all serves on your board?
So we have Susie Ames, Tom Sanford, Janet Lucas, who's a professor at the college, Jennifer Swanson, who's with First Fed, Ruth Cook, who's with the PUD, David Chance, who's a retired dentist, Jody Moss, who's retired. She was with United Way and other social service, Olympic area on aging. Trying to do this all mentally. Bill Bacchus, who's with National Parks, a scientist. Tom, Susie, help me out. Who's not jumping in my head? I think that's.
I pulled up the website to help me.
Thank you.
I didn't hear every name you said, but Bill Bacchus with the Park Service, John Brewer has recently passed, as folks is aware, and it's a big hole with our board and lost the community. David Chance, Ruth Cook, who's with the PUD, Janet Lucas with Peninsula College, Allison Mahaney, attorney at First Federal, Jody Moss, as Mike mentioned, Stacy Ritchie with Port Angeles School District, and myself, and Susie Ames as well. Oh, I'm actually saying our Mike, our website's out of date.
Oh, I got to talk to Jeff about that. Bummer. Okay.
All right. Well, great. So really terrific information. And yeah, I think it has kind of gone under the radar, the impact that NOHN made and what a huge deal that was, that you guys got to be a federally qualified healthcare center or community health center. So yeah, that was a big win. And everybody needs healthcare. And I just remember years ago where no one could find a physician, and I ended up, for my family, going to a boutique, where you pay the extra $85 per person per month to have services. So yeah, it's so important for everyone. And we just appreciate you and your involvement in the EDC, and then also, of course, everything that your entire team does at in Clallam County. So thank you so much for that. And does anyone have any other last minute questions? Cindy does. Cindy.
Mike, thank you very much for all the work you've done. It was a pleasure to be on the school board when we did the mobile unit, and our families really need it and they continue to need it. I would just like to ask you what your collaboration is with our local tribal health services. Most of our tribes all have health facilities, and what kind of collaboration you've done there.
Yeah, that's a good question. We collaborate most closely with Jamestown. They're part of the OCH, and so we do a lot. We don't have any joint programs, but we share a lot of information, and so have worked together on some of these OCH projects. Brent Simkowski and I, we meet regularly, and in fact, he and Eric and I used to meet regularly about overall kind of planning. We have talked with Lower Elwha. There's some originally around some like access to psychiatric services, but there was some I can't remember the details, but there were just some regulations that kind of made it difficult to implement. But we don't have any active specific programs together other than kind of shared visions, shared philosophies. We know that the tribal health takes a very similar integrated comprehensive approach. And so nothing's really tangible yet, but we're open to anything, any way that we think we can help or work together. We're open to it. Just we haven't identified what that specific thing is that we can do together.
I would just encourage you to do consultation with the local tribes. Reach out and, of course, lots of people think it's one and done, a meeting, but unfortunately it's not that.
Yeah.
But yeah, just reach out to the tribal council first and see, because I think that, you share a lot of the same issues, especially reimbursement stuff. But thank you for the services you provide our community and across our county.
Thank you very much, Cindy.
Yeah. Matt, do you have any thoughts? He worked in the healthcare industry for years.
And you survived, Matt?
Yeah. After 35 years, I decided to jump out and find another fire to jump into called municipal government.
So much easier. Yes.
Yeah, from one burning platform to the next, right?
Right.
Yeah. So anyway, no, it's all about survival, right? So how can you get to the next year? No, I love what you do. I love your model. Congratulations. Super supportive. Just need to clone you and your team and let's go. So no, super impressive.
Well, thanks. I do want to call out and Squim. Jamestown does their tribal lookalike. They essentially function as a community health center, and they just do a really good job. I consider them a sister of another mother. We really are very aligned in our approaches, and Squim's fortunate we're all fortunate to have them in the community. Let's call
well, we've got that free clinic. It's not near as sophisticated as what you're doing. But it's trying to extend, services to the underprivileged and those that need some help. And I came from Park City and Utah, and they had a community health program there too, because they had a fair amount of underserviced people that really had, healthcare concerns. So I've always, of course, been a fan of that. So yeah, I'm just so glad that you're here and doing what you're doing for the peninsula. So thank you.
Thank you very much.
Great. All right. Well, everyone, thank you for joining. And Dr. Maxwell, again, our sincere thanks to you and your team. So enjoy your morning, everyone. And we'll see you around. Actually, next Wednesday, I won't be here. I'm going to be on vacation, but May 8th, we're going to have Seabrook on. So that should be interesting. They'll talk about their concepts, potential project around the John Wayne Marina. Okay.
Great. Thanks, everyone. Bye-bye.
Mitch, who's on next Wednesday?
I have column emergency management and
Okay,
we'll
great.
be on. And
And
yeah,
so-
that'll be a good one too. So tune in.
All right. Terrific. Thanks. Bye, everyone. Bye, Lena.
Do you have a second?
I do.
Okay.